So this was an awesome, incredible podcast with Danny Lennon of Sigma Nutrition. All we talked about was hypertension. Like literally, that is it. The whole episode was on hypertension, how to treat it, what causes it, how to reduce your blood pressure naturally, what medications can you use if the natural route doesn't work, online myths and medfluencers and, stories about stuff like that. But I think you guys are going to love this one. I highly encourage you to watch it. Give myself and Danny a follow. Leave us some awesome reviews on your favorite podcast player. Search for the Dr. Allo Show or Sigma Nutrition and give us a follow. You guys are going to love this one.
Here we are. A big welcome to the podcast to Dr. Mohamed Allo. Thank you so much for taking the time to come and join me today.
Thanks for having me.
Yeah, I think I may have mentioned to you in some of our communication that I've enjoyed the way you've been taking some of the content that is not only some of the most important for some of the things you're discussing, but also is the one that has a lot of misinformation and even disinformation, I would say, unfortunately. And you do a good job of bringing your clinical experience into understandable information for people. And so hopefully we're going to see a lot of that throughout this discussion. But before we get to that, can you maybe give people listening an introduction to you, your background in terms of academia and work, and anything else that might be relevant to frame the rest of our conversation?
Awesome. Well, thanks for having me on. So like you said, my name is Mohamed Allo. I'm a cardiologist. I'm board certified in internal medicine and cardiology. That's just how they do it in the United States. You have to finish internal medicine first, then you do cardiology. Cardiologists treat all sorts of cardiovascular, cardiometabolic disease, in addition to procedures that we do, putting in pacemakers, doing cardiac catheterizations, reading imaging studies like echocardiograms, cardiac CTs, cardiac MRIs. I grew up mainly in Ohio. I live currently in Toledo, Ohio. I did all my medical training in Chicago, and then I moved back to Ohio because my entire family lives there. I love educating online. I have a YouTube channel that I've been updating since before it was even called YouTube. I started back when I was in medical school and finishing up there. People enjoyed my lectures and they're like, hey, can we get a copy of your PowerPoint? Can you put it online? Can we download it? So I started doing that. So I usually request to have all my lectures and videos recorded and put online. Some of them I do more than one, so I don't put multiple copies of the same one over and over again. But it's a lot of fun. I love teaching. Like you said, I've recently started doing more of the short form videos online. That's probably how you found me. The long form videos have always been there, since 2009, maybe 2008. And I've started putting out these little short videos because they're, the people have a shorter attention span. They like quick hitters. Like, what are the top 2 things you can do to lower your blood pressure, improve your cholesterol, help your diabetes. There's a lot of misinformation out there on the internet. I'm sure you've noticed, in the nutrition field and fitness world, you've got like these Gary Breccas of the world and other people that are basically telling you that water doesn't hydrate you unless you buy his special wand that you need to mix your water with to hydrate yourself, which is obviously a bunch of nonsense. And people buy into this stuff. They think, oh my God, I can't drink water anymore and I got to add a little bit of salt to my water to make it hydrating, or have to put it through this infuser and buy the special ionized something water, or there's all kinds of misinformation out there whether it comes to eating. I am a certified personal trainer too. A lot of people don't realize, they say, well, what do you know about nutrition? What do you know about building muscle or working out or lifting weights? Well, I'm a certified personal trainer. I coach a lot of people on just that. I coach a lot of youth sports. I coach, you call it football, we call it soccer. I coach American football too, tackle football. I've coached, thousands and thousands of athletes. So I'm very into working out, bodybuilding, the nutrition around athletic performance, all that kind of stuff. So it's fascinating to me, and it's something I'm very passionate about. It works really well with cardiology, putting those 2 things together. Somebody who wants to be as metabolically healthy as possible, what kind of diet works for that? What kind of things should you be doing? How should you be training? What sports do you play and how should you train for those sports? All those kind of topics are very fascinating to me. So I've started putting some more of these things online in these short form videos, and people seem fascinated by it. They like it. They share it. I get over 5.5 million views a month now, combined on all, different platforms. So hopefully I'm doing something right. Hopefully I'm educating people, and hopefully people will use that as motivation to seek more knowledge, and seek correct knowledge, going to the right experts for the right topics, so that they're not, learning the wrong things. One thing I always tell people is, I don't know about your brain. Don't ask me about brain surgery. Don't ask me how to fly planes. I don't know anything about that. I would be lying. If I went and Googled it, that would be a terrible idea. But you can ask me everything you want about the heart, cardiovascular disease, cardiometabolic disease. That's what we do. So that's something I could talk for 9 months straight about. But definitely, I don't like to venture into fields that I don't know about. And I think one way you can tell if somebody's an actual expert is when they say, I don't know. A lot of these medfluencers and healthfluencers online, they know everything. You ask them about your eyesight and they know, and you ask them about getting sunlight and they know, and you ask them about broken bones, they know everything. I mean, that one sign of how you can tell someone's a true expert or not is they have advice for everything. There's a bunch of these people that are not even physicians, but they have a doctorate degree in something, and they tell you how to pick up women, and the next video is about how to improve your potassium something, and how to make your water this, and why sauna is the greatest thing for you. They have advice on every topic you can imagine. That generally means that someone is not an expert. But when they talk in nuance and they say, well, generally speaking, here's what we do know about this. For most people, it's this. For some people, it's not. When they talk about that, but it's not sexy, so you don't get a lot of play. I mean, you don't have millions of followers, but if you go tell people eating peanuts is going to kill you, you'll get 1 billion followers because it's controversial. It's crazy. It sounds insane. People share, oh my God, look what happens if you eat peanuts. It's going to kill you, just crazy stuff. But anyway, it's kind of a little bit background information, and hopefully I can help educate your audience, and they can help educate me too.
I like what you just said, because it gets to a great heuristic for people to use when they're looking for information online, right? Of if you have someone who positions himself as that source of all knowledge, that immediately is your red flag. But unfortunately, that's the type of thing that becomes, I suppose, attractive to many people online. I mean, we can even look at the most successful scientific communicators, where they will do their own solo podcasts on every topic imaginable, which are well outside their field of scope. So, but today, as you mentioned, we're going to be talking about cardiovascular disease. Obviously, even if we look at a worldwide perspective of our risk of mortality or morbidity, is one of those, or probably the most important risk factor. And within that, there's many things under that umbrella. Of course, we could have spent a whole bunch of time talking about blood lipids, which is one of the things that we like on this podcast, and maybe that's for a future conversation. But one of those other huge pieces is blood pressure, and looking at hypertension and some of the things that can kind of cascade and cause some real issues. So I'm sure people are familiar that, okay, we've got this thing, blood pressure, and if it's too high, it can be a problem. Could you maybe just actually paint a picture for us of what are those actual implications of elevated blood pressure? So how does high blood pressure actually lead to cardiovascular disease or cardiovascular events at some later time point?
Right. So blood pressure is very, problematic. It's one of the leading causes and contributors to most, cardiovascular or cardiometabolic diseases. We usually identify a blood pressure of 115/75 as normal. And for every 20/10, so like 115 is normal, you add 20 to that, over 75, you add 10 to that. So for every 20/10, your rate of stroke doubles. So at 135, it's 2 times more. 155, it's 4 times more. 175, it's 8 times more. And 195, it's 16x, 16 times more the rate of stroke. So blood pressure is one of the largest contributors to strokes. Obviously, strokes are brain attacks, and in your coronary arteries, it would be called a heart attack. So the amount of damage that is being done by high blood pressure is what causes these arteries to ultimately stroke out. And the shearing forces, the high pressure, lots of little micro bleeds, that happen into your brain even. So blood pressure it's a huge burden. There's different things that cause high blood pressure. Number one is usually we call it essential hypertension, which just means genetically high blood pressure. You didn't do anything wrong. You didn't eat too much salt. You're not too obese. Young people, 15, 20 years old can have this. But obviously, as you get older and you gain some of these, you gain weight, you eat, a bad diet, you have too much salt in your diet, not enough potassium in your diet, those kind of things absolutely can worsen that. Just like with all things, you're born with genetics for higher cholesterol or a certain number of cholesterol, and things you do or eat can make it worse, just like diabetes. You may or may not be born with genes for diabetes, but if you are and you gain weight, get put on birth control, take steroids, are less active, eat too much, those kind of things can worsen your insulin resistance. So definitely blood pressure is one of those things where it, like anything, there's a large genetic component, but there's also lots of things you can do about it. Eating more fruits and vegetables. There's this diet called the DASH diet. And it's very similar to the Mediterranean diet. You currently live in Spain right now. So I'm sure you're familiar with, a Mediterranean style diet, lots of fruits and vegetables, olive oil, nuts, legumes, lean meats, etc. The DASH diet takes that and just takes away alcohol and salt. Alcohol and salt are major contributors to hypertension. It's called the dietary approach to lowering blood pressure, solving hypertension. So it's called DASH, DASH, all caps. You can easily, your audience can look that up. But it's basically a Mediterranean style diet minus the alcohol and salt. Technically, according to the American Heart Association, it is the highest rated, healthiest diet. Second would be the Mediterranean, any Mediterranean style diet you want. Now, some people, are more plant-based and don't want to eat meat. Some people will eat only fish. Some people eat only eggs and milk, dairy. It just depends, how you want to modify the Mediterranean diet to fit your preferences, your dietary preferences. But those style diets generally will help lower your blood pressure. When we're diagnosing blood pressure, generally we want to get at least 2 readings that are separated. We have the patient come in, one day and it seems high, and we do it, a few weeks later and it's still high. That's when we would treat them. Now, we don't treat them if they're just 135, 128, we don't go crazy. Obviously in the beginning with blood pressures under 140, we have them try lifestyle, which is like more exercise, stop smoking, stop alcohol, reduce salt intake, more fruits and vegetables, more potassium, and fruits generally have a lot of potassium. Those kind of things, lifestyle modifications. If they are still high, they lost the weight, they stopped smoking, they stopped the alcohol, they did everything we asked them to do, they changed their diet around. If they're still high, and by high we mean over 140, if they're consistently over 140 systolic, then we say, okay, now it's time for a blood pressure medication. And depending on the person, how old they are, what other comorbidities they might have, we may select a medication that matches their profile. Like, for example, if you're a diabetic, ACE inhibitors do really, really well because they protect diabetics' kidneys. If you have coronary artery disease, you've had a heart attack or stroke, for example, a type of certain beta blockers would help. If you have BPH, a prostate that's enlarged, alpha blockers would be useful. If you have certain types of heart failure, maybe diuretics would be helpful. So it really depends on the person and what they have. We would decide which medications to put them on or not, put them on, depending on how much they've been able to lower their pressure on their own, if that's even possible. We also need to look for what we call secondary causes of hypertension, and these are other genetic things that may be causing it. A big one now is sleep apnea. One of the number one causes of high blood pressure right now is sleep apnea. And this is a condition where when you are sleeping, your neck is so heavy. It's usually obese people, but obviously there's a small percentage of people who have sleep apnea that are not obese. It's just the anatomy in the back of their throat. But usually you're obese. Your neck, when you go to sleep, your neck and your brain paralyzes you from the neck down. Because if it doesn't, you're going to have these dreams. You're going to get up and run around and do these dreams. So your brain paralyzes you from the neck down. but that paralyzes these muscles and these tissues, and they collapse your airways, and you're not getting enough oxygen. So every few minutes, your body sends a huge adrenaline rush, and adrenaline wakes you up, but also adrenaline raises your blood pressure significantly. The adrenaline, the epinephrine, they call these catecholamines, adrenaline, norepinephrine, these things really blast your system with very, very high blood pressure and very, very high heart rates. So obesity, related sleep apnea or sleep apnea is one of the number one causes of very difficult to control blood pressure. And that's one thing we need to work on with patients. Like, hey, if you are overweight and have obesity, you need to lose weight. You need to maybe get on a CPAP machine, what have you. We have to get these patients to lose weight. Another common cause or secondary cause of blood pressure problems is something called a pheochromocytoma. This is a small tumor, in your abdomen that secretes adrenaline, secretes these catecholamines. You get this rush of catecholamines every few days, sometimes multiple times a day. You'll be sitting there totally fine, blood pressure 100, 108, over 68, and all of a sudden you're 228. You get this huge adrenaline rush as if like you're on a treadmill running like crazy. So you get these wild fluctuations in your blood pressure. They're hard to diagnose. You need a CT scan. You need to do blood tests called serum free metanephrines. And once we diagnose that and we do a CT scan, if we find the tumor, the job would be to obviously remove it. Young women get this disease called fibromuscular dysplasia in their renal arteries. Your renal arteries, if they're tight, will cause a high blood pressure. In women, they get it because of this genetic condition, especially younger women. Men usually get it at an older age, and it's due to the atherosclerosis. It's due to plugged up arteries. Like, you'd have the rest of your arteries could get plugged up from, high cholesterol and various other things. That would be another secondary cause of hypertension that we need to look for. We do renal ultrasounds. We look for tumors on your adrenal glands, even, near your kidneys. But those are all conditions that can cause high blood pressure that aren't the usual just straight up high blood pressure. So if we find one of these conditions and we treat it, let's say you're just, super overweight and have sleep apnea, we can treat that, whether it's, diet and exercise. Obviously, we always start there. Diet and exercise, get into a calorie deficit, try to lose weight. If you lose enough weight and the sleep apnea goes away, that's great. If not, and you're still hypertensive, then we have to obviously treat it. Now, obviously, we're not going to leave you and not treat you in the meantime, because blood pressure can be very devastating. I've seen patients, I'm sure you've seen people, maybe have family members that have had strokes where a blood vessel bursts in their brain and they have this bleeding, huge, massive hemorrhagic stroke. There's two kinds of strokes. There's the one where there's a bleeding problem, and then there's one that's like a heart attack where like a plaque breaks off your carotid arteries and goes into your brain, sort of like a heart attack, just plugs up an artery. Those kind of strokes are devastating as well, both of them. And the more of these risk factors and conditions we can control, the better the blood pressure will be. So hopefully that's kind of a really good general overview of blood pressure.
Fantastic. And a number of things within your response there that I'd love to dig into individually. One that I think is a crucial point that maybe sometimes isn't appreciated is that you noted that because there are these potential different explanations for why a certain individual may have high blood pressure, that if we don't look and try and find out, well, what is causing this high blood pressure in this person, then we're kind of trying to treat it blind almost, right? Because if we, rather than saying, oh, this person's blood pressure is high, let's maybe just medicate that to bring that back in range. But if you haven't screened for something like sleep apnea, as you mentioned, now you're missing actually treating something that you want to treat because it's going to cause other problems. So this idea of trying to understand not just what the diagnosis is, but what is that cause underneath.
Yeah, a lot of people criticize doctors saying we don't look for the root cause, and that's why they turn to these medfluencers or healthfluencers, because they say, well, you guys aren't looking for the cause. Well, we are, and we know these causes. Like when you come to me for blood pressure, we may have to put you on a medicine right away just to get your numbers down, because if your blood pressure is 180 or 190, that's a huge problem. And then we tell you, listen, you're severely overweight, you have sleep apnea, we need to check your renal ultrasounds, we need to check these blood tests called serum free metanephrines. We do check all these things. obviously, we try to find root causes if they exist. Now, they don't always exist. Pheochromocytomas are super rare. Sleep apnea is very widespread, obviously, all over the world with the obesity epidemic. That is quite common. And obviously, we can help the patients as much as possible. Now we have medications that are, amazing at helping people with weight loss too. But a lot of that is up to the patient. I can't force patients to not eat as much, be more active, what have you. I can refer them to dietitians, to personal trainers, to, health coaches, what have you, but I don't live with the patient. I do also do obesity medicine. So I do help patients with obesity, medical weight loss, we call it, or obesity. I even sit there with them and I set up a calorie deficit on MyFitnessPal or the Carbon Diet app, whichever app they prefer. We've had success with weight loss, just straight up normal weight loss, like the old fashioned way. Here's your calorie deficit. Here's how much you should eat. Go. And we check in with them once a month. And some people will do that and lose weight. It's not a huge percentage of people. Now with the new weight loss medications, combining some of the newer GLP-1s like the Ozempics, the Wegovy's, the Trulicity's, Victozas, Mounjaro, Zepbound, whatever, they have different names. But combining these new GLP-1 medications with some of the older medications, we're able to make people lose weight almost effortlessly. I mean, you put somebody on a combination of 3 medications and they come back next month and they've dropped, 10 or 15 kilograms or, 30 pounds and over here. So you get these tremendous results now that's almost effortless. It's almost like a cheat code, which is very nice. I've had patients that used to come in on a motorized wheelchair because they just can't move. They're almost 500 pounds, which is, 250 kilograms. They're very large, obviously. And then 2 months later, they walk in, because they lost, 35 kilograms or 40 kilograms, 80 pounds, and now they can walk. They don't need the motorized wheelchair anymore. So these medications have been life-changing. A lot of people don't like using medications to treat problems, but if this can kickstart somebody's health journey and they lose 100 kilograms or they lose, a lot of weight and they, get motivated and now they can walk and now they can go to the gym, now they can swim, now they realize that they can eat healthier because they got this huge head start or this huge boost, instead of going for gastric bypass surgery or whatever. This is a tremendous improvement in lifespan, health span, quality of life. They can get up and do things. They can play with their kids or grandchildren. They can go to the gym and play themselves. So these medications have been life-changing. And obviously, we don't just, put people on a medicine and say goodbye, but also a lot of the responsibility is on the patient. I can only do so much. We have to see 30 to maybe 40 patients a day, sometimes more. And I can't sit with every patient for an hour and explain all these things to them, which is why I do a lot of these videos. I put them online on YouTube or, various platforms to help people kind of learn the rest. I have a YouTube playlist called the Ultimate Weight Loss Playlist. And a lot of them are long lectures, like 3-4 hours that I've given at medical conferences. And I tell my patients and other people, look, if you actually get through my weight loss playlist on YouTube, you'll have a PhD in weight loss. But you have to care. You have to go do it. I can't make you do it. I can't force you to do it. If you want to lose weight properly and understand metabolic adaptation and how many calories to start with and how all the different macronutrients work and which ones to choose and which apps to use and how to set it up and what the data shows on intermittent fasting versus keto versus balanced diet versus, whatever. There's all these, different kind of diets you can try. What does the data and research say about all of them? You can select whichever one you like, but you just have to be able to do it long enough. But you can pick, anything you can do for short term and then switch to something long term. I mean, there's all kinds of strategies people can do to get weight off and improve their life and their, quality of life. So I point them in those directions. But of course, I don't live with them. I can't make them do these things. They have to want it. You probably have seen this in your practice when you talk to people like, hey, listen, here's what we need to do, but they need to be motivated to do it. Being a health coach or part of a, nutrition community, people have to want it. You cannot just hand people a piece of paper or a bunch of videos to watch or help them set up MyFitnessPal and then they go home and do nothing. Right? I mean, you can't make them do it, but we try, and the healthcare system isn't always set up perfectly, correctly in a way to help people with some of these things, but we do our best. And, we try to do what we can. We try to motivate people. We try to be inspiring. We try to set up their apps for them. But like I said, a lot of it is going to be on the patient, and they have to want it. Just like quitting smoking. If they don't want to quit smoking, no amount of medication is going to help you quit smoking. So, those are my thoughts on that.
Yeah, no, it's a great point, and I'm sure we'll go through in a bit more detail different options specifically as they relate to blood pressure, for example. And we can look at medication and some of those lifestyle changes. But I think what you just said raises a really important issue. That is one of my something that gets to me sometimes, where people paint this binary between medication and lifestyle as if you have to choose one or the other and that's it. Whereas for many of these things, particularly where we have really effective, safe medications, for example, as we'll probably talk about in relation to blood pressure, but also, for example, someone taking a statin if they've elevated cholesterol, trying to say that, oh, you shouldn't do that. You need to wait a certain period of time and try all this other stuff. Maybe for some people, if they want to do that, but also if someone has a really high LDL cholesterol, why can't you kind of do both? This kind of binary that sometimes people paint, and there's a whole host of other things that go into the kind of anti-drug, anti-medication ramblings you sometimes hear online. So we'll definitely get into that. Oh, a couple of things that you've mentioned I think are quite interesting that I'd like to get to. In terms of actual targets for people, if they're looking at their own blood pressure, whether that's something they get checked with their doctor regularly, or whether they maybe even have a cuff themselves, kind of consumer cuff that they use at home, and they're trying to keep a monitor on this. You said that clinically, you would start intervening if someone has a consistently high blood pressure that's above 140. That's where we need to do something. If it's much above that, it probably even more urgent. But for people that are maybe in that gray zone, so let's say that their systolic blood pressure is above that 115 mark that you mentioned, maybe it's 125, 130, maybe a bit above that, in this type of range where it's not a intervention is needed right now. It's something that we want to be monitoring, but probably is something you don't want to necessarily have ongoing. How do you conceptualize what is, first of all, where you're intervening for people, but second of all, what would be a good ideal target if such a thing exists, in the sense of number one, how long could someone feasibly be in this gray zone of blood pressure that's slightly elevated before it's something you are really worrying about? And then from there, some typical targets you have for your own patients.
So I would say most people walking the earth have a blood pressure in that range that's not. So the people that are not treated, let's say, almost everybody's blood pressure is above 115. I don't know that many people, other than my POTS patients who have extremely low pressures, like in the 70s and 80s, and are always passing out. That's, the other extreme. But the vast majority of people have a blood pressure under 139, and we don't do anything. I'm not going to treat somebody who comes in at a 125, 120. We're going to say, hey, listen, maybe it's a little high, but it's not dangerous. It's not going to kill you, long term. You probably don't, you just don't treat it. I mean, none of the guidelines say to do anything. Definitely part of the problem is you don't have a real accurate, it's not like perfectly accurate the way that it's measured. So you don't want to just assume that. Now, some of the elderly, we don't treat them, because their arteries are more calcified, or maybe not calcified, but more lack compliance. They don't, they have a lack of compliance. They're older arteries. Most arteries, open and squeeze and relax very easily. The elderly don't. So I just wanted to mention that the elderly, we don't want to over-treat them, because then they get lightheaded and dizzy, and they start, they act sort of like they have dementia because they're not getting enough blood flow to their brain. So the elderly, we would treat them, we would have them stand up and only check their pressure standing, because it has a huge drop. So the elderly, we're a little more cautious. And by elderly, I mean, probably over 70. We're just a little more cautious with them, and we don't over aggressively try to bring them down too low. So if they're hovering in the 140 range, on meds or whatever, we'll check them standing, just to make sure it's not like a huge drop. And if they drop into like the 120s, 130s, it's fine. We're not going to be super aggressive about getting them down to around 110 or 115, because they just have problems. the medications can really precipitate a large decline in blood pressure, and they can be wobbly, they can't walk, their gait is affected, they're lightheaded and dizzy all the time, they seem like they're out of it, they're confused, their brain's not getting enough perfusion, and it's just not a good situation. For most people who are below 140, it's mostly lifestyle. We're going to say, listen, your pressure is 125 to 135 all the time. You don't qualify for any meds. You need to exercise more. You need to eat more fruit, more vegetables, more fiber, stop smoking, stop alcohol, eat a Mediterranean style or DASH style diet, and be on your way. Most people in that range would never get treated. Now, if they have a very elevated blood pressure, like you mentioned, in the 160s, 170s, that's dangerous. They need to be treated in the meantime while they are working on their lifestyle. So yeah, like you said, it's not mutually exclusive. You don't just say yes medicine or only, you don't have to choose either medications or lifestyle. They can do both at the same time, because this is a very dangerous condition. And it's like that for most things. Like, you would never tell a diabetic, we're not going to put you on medication. We're going to let your blood sugars be in the 700s until you lose weight or whatever. That's like, you're killing them. Same thing with cholesterol. Somebody has a LDL cholesterol of like 200-300, you're not going to say, yeah, let's work on your diet for, that would make no sense. You have to get them out of immediate danger first. And it's more profound with blood pressure, because blood pressure can like instantly give you a stroke. One spike to 220, 240, and you could have almost an instantaneous, horrific, life-altering event. So with blood pressure, we're a little bit more aggressive. Obviously, diabetes and cholesterol are more of a longer, chronic over time exposure. It can be a problem. Obviously, if you're a type 1 diabetic, that's a different story. And if you're having acutely high, blood sugar, like in the 600 or 700 range, that's a different story too. But someone who's like slowly, chronically getting up there, with their blood sugars in the 100s, 150, 160, just chronically, slowly getting up there, similar to like a blood pressure, it's going 140, 150, back down to 135, then 155 again. You have time, with those kind of patients. You can treat them, obviously, with medications until they lose the 40 or 50 pounds, 15 kilograms, what have you, or get down to an acceptable weight, start an exercise or at least walking program, start eating more fruit, more vegetable, getting used to more fiber, those kind of things. So like you said, it's not either or. In some cases you have time, in some cases you don't. So definitely we would tell those people that are under the 140s mainly to adopt lifestyle modifications that would help bring their pressure down without medications, unless they're in immediate danger.
Fantastic. And we will revisit some of those lifestyle modifications. But just to continue on those medications, let's say we do have a situation with someone who has a significantly elevated blood pressure. It's something that needs to be treated straight away. Can you maybe walk us through some of the main categories of medications in this area? What are the most commonly prescribed groups of drugs? And then beyond that, for you clinically, what goes into that decision-making process of which drug I might choose for a certain individual, at what dose, etc.?
This is a perfect topic, because I just uploaded a YouTube video on how a cardiologist treats hypertension. So there's a lot of detail in that video if you guys, if your audience wants to go watch it. But generally, there are different classes of medications. There's the first place that I start, the guidelines recommend starting with one agent if possible. And in some rare cases, it would recommend adding 2 small doses of 2 agents rather than 1 agent. But let's just go through the categories. So the first category, we'll call them ACE inhibitors. These are a class of medications that affect the hormonal system, mainly that communicates between your kidneys, your lungs, and your vasculature. And an ACE inhibitor, it would be medications like lisinopril, captopril, benazepril, anything that ends with the word pril. Funny thing to note, your audience may like this one. Guess where these medications came from? They came from a very naturally occurring substance. Take a wild guess.
You got to tell me.
These came from viper venom. The snakes, the vipers, they would bite a human and inject a bunch of this ACE inhibitor. It was captopril. Inject a bunch of captopril into you. Your blood pressure would drop so low that you wouldn't perfuse your brain or your heart or your kidneys and your organs, and people would die.
So we've isolated that molecule. And this is another interesting thing. Like almost all of these medications that I'm going to name, at least all of the medications we use in cardiology, started from somewhere in nature. So a lot of people online will just say, why are you using medications? Why don't you use natural remedies? Well, they are. They're all natural remedies. Like statins, for example, they come from yeast. Most blood thinners we have come, like aspirin is from willow tree bark or oil of wintergreen. Sweet clover is Coumadin or warfarin, the other blood thinners. So all of these medications come from something in nature, but you can't tell someone to go and eat willow tree bark because you don't, it's not enough, it's not a concentrated amount of the oil of wintergreen or the salicylic acid. And what if they eat too much, and something terrible happens, what are you going to do? So it needs to be regulated. In the United States, the supplement industry is not regulated, but obviously medications are. I'm sure it's very similar in Europe and other countries. So lisinopril is the most common one that we use. The molecule obviously comes from viper venom, and it's a very, very potent blood pressure lowering medication. That's generally where I start with most people because it has a very favorable side effect profile. People don't get fatigued. They don't feel sluggish. It doesn't have any erectile dysfunction issues, and it doesn't, it's not diabetogenic. Some of these blood pressure medications have a little bit of an effect of pushing you a little bit towards diabetes. Obviously, if you have the genetics for diabetes, it's not going to take somebody who's not diabetic and make them diabetic. But if you're a little bit insulin resistant or a lot insulin resistant, you're very diabetic, it'll push you, a little bit over that. Beta blockers do that, and the thiazide diuretics do that. So lisinopril does not. So it's a great starting point. The problem with lisinopril and these ACE inhibitors is they can give you a dry hacking cough. A lot of people, because of the way it affects the lung parenchyma and some of the hormones in your lungs, bradykinin especially, it gives you this weird dry tickle in your throat and in your airways, and you get this really weird dry cough. About 3 to 5% of people get that, and we usually at that point in time will switch them to something called a ACE angiotensin receptor blocker. Which is on the other side. So there's the ACE receptor that affects this side of the equation, and there's the ARB or ARB that affects the other side of the equation. These are the medications that start with the words that end with a tan. So it's like losartan, valsartan, telmisartan. They all end in artan. So those medications are also very potent, very powerful. They have minimal side effects. They're not as potent as lisinopril for lowering blood pressure, but they work very, very well, and also can be used, with people with kidney disease and various conditions. Diabetics generally should be on an ACE inhibitor because it's renal protective in their scenario. So we definitely want to make sure, even though if they have diabetes, and the lisinopril will protect their kidneys from damage. So diabetics generally should be on an ACE or an ARB. People with heart failure should also be on an ACE or an ARB, and that's a whole other lecture. But that one's on YouTube too if you want. But definitely that's where I start with the medications. You can start almost anywhere, either an ACE inhibitor because it's the most potent. Even at a low dose, it gives you very good blood pressure lowering effects with minimal side effects. If they get a cough or they don't like it or something, we switch them to losartan, which is the ARB, the ARB, which is an angiotensin receptor blocker, which works on the other side of the same kind of general hormonal area. There are also medications called thiazide diuretics. These would be medications like hydrochlorothiazide or chlorothalidone. They also work, quite well, even at really low doses. They basically make you pee out salt in a way, and that lowers your blood pressure. They are a bit of a diuretic the first few days that you take it. People think they're diuretics. They are called thiazide diuretics, but they're generally not very diabetic after the first 2 or 3 days. They're more of a vasodilator, and all of these medications generally work by vasodilating your arteries. Even the ACE inhibitors and the ARBs, same thing. But the thiazide diuretics work as a diuretic for a few days when you're peeing out salt, and then mainly they work as a vasodilator. So that's how they work. And usually if somebody needs really strong blood pressure lowering, like if somebody comes to me and their blood pressure is 180, 190, and we really need to get them down, sometimes the highest dose of lisinopril by itself will work. So we'll put them on like 40 milligrams and see how they do. I can almost guarantee you they'll be at 110, 125, most people. If they're a little bit resistant and that doesn't work, you can add a little bit of a thiazide diuretic, and that generally
will drop them. That combination is very potent. Same thing with a ARB plus thiazide diuretic. They work very, very well together. The next class of medications that you could use would be beta blockers. These are like metoprolol, carvedilol, labetalol, propranolol, all the olols. My favorite one to use for blood pressure would be carvedilol, because it actually does lower blood pressure directly. The other ones like metoprolol and atenolol generally only slow your heart rate down and don't have a very potent blood pressure lowering effect. The problem with these medications, because they block adrenaline, is a lot of people will feel fatigued, tired, lack of ambition. They're not as energetic. They might put on weight because, they kind of blunt all that, kind of response, and they block adrenaline. So people feel kind of, all those kind of things, fatigued, erectile dysfunction, even lack of libido, lack of ambition, lack of energy. Now, elderly patients don't seem to mind it as much, but definitely younger people, below the age of, I'd say 40 or 50 would definitely notice it. Not everyone, some people do need them and they take them. Some of them don't block adrenaline as potently or as much. And sometimes at lower doses, people don't notice anything. Because they block adrenaline, people can gain weight on them, which is obviously something we're trying to avoid. But that's also not a huge percentage of the population. Now, once you start stacking medications on, like let's say they're also on antidepressant medications and other things, if you're on multiple medications that can cause weight gain, some people will gain weight, obviously. But we try to overall select medications that work with the conditions that people have. There's also calcium channel blockers. These can be divided sort of into two categories. One of them is called the dihydroperidones, which do directly vasodilate your arteries. These are like amlodipine, nicardipine, nifedipine. They end in pene. And then there's the non-dihydroperidones, which don't end in pene. These are basically verapamil and diltiazem. Those act as medications that slow your heart rate down. So they act more like some of the beta blockers. They act like metoprolol and atenolol, whereas the amlodipines and nicardipines are more vasodilators. The next class of medications, there's one called hydralazine, which is also a vasodilator. Sometimes we use nitrates, the long-acting nitrates, not that often. There's another medication called minoxidil, which is a very potent vasodilator. A lot of men like it because it also causes hair growth or like a lack of hair loss, let's say. But minoxidil is a very potent vasodilator. We use that one kind of at the end. If we've maximized everything else and they still need some blood pressure lowering, minoxidil could be an option in that case. Those are kind of the main medications that we use for blood pressure control, probably in that order.
Fantastic. That's really useful. And within that, it seems that there's a variety of different options, and depending on a patient's circumstance or the degree of blood pressure lowering that's required, that would dictate which option you're selecting, or certainly what dose you're going for. From your experience and seeing people who are then, let's say, prescribed a pretty standard dose and it's a pretty standard patient overall, presumably there's still going to be some variation from person to person in their response to that initial prescription. Can you maybe give an idea of what variability you might see across patients prescribed a certain dose, if at all?
Yeah, so there's definitely, so there are studies that show a given response. Like if we put somebody on low sartan, let's say 25 plus hydrochlorothiazide 25, we know that drops most people on average by about 30 points on their systolic blood pressure. We know that, for example, lisinopril 5 for most people drops their blood pressure 5, or 10 or 20 points, what have you. So I think, and part of it as a clinician, you get used to it. Like I can almost, like if you told me your LDL cholesterol right now and told me you're starting Crestor 5, I can tell you probably within 3 points what your LDL cholesterol is going to be the next time you get it checked. Mm-hmm. So you get used to the amount of blood pressure lowering you get with medications. Like I usually get sent patients when the family doctor or their primary care physician, like this is too complicated of a blood pressure problem, go see the cardiologist. So to me, they send me a patient
who's probably maybe not been optimized or maximized on medications, or they're just too complicated. They want me to do the secondary workup with the sleep apnea, the renal artery stenosis, the pheochromocytomas, the renal ultrasounds, what have you. So we'll get those patients. We can get their pressures down. Like, to me, when somebody sends me a patient like, I can't get this guy's blood pressure down, don't worry. We can get it down. We have an arsenal of maybe 15 up to even 30 sometimes medications we can use to get someone's pressure down. I'm not worried about getting it down. I'm worried about why is it so hard to get them down? Why are they not responding to the usual suspects in terms of medication? Like they put them on lisinopril 10 and it really didn't budge, or they put them on the maximum dose of lisinopril, 40 or 30 twice a day or whatever, and their pressure didn't even move. What's the idea? What's going on there? So when they send them to me, we have other things that we can use at our disposal. And, that's all we do. We deal with the cardiovascular system. I don't deal with their foot pain and their headache and their migraines. I deal with only their blood pressure, their cholesterol, their diabetes, their aortic stenosis, their valve disease, whatever. So to me, that's my unique specialty. We can get them down. The question is, how much lowering do you need it to go down? And how can we do this in a way that maximizes or lessens the harm to the patient? Because if a patient is, let's say, very old, sort of demented, and you put them on hydrochlorothiazide, their sodium can get very, very low, which is makes them very confused, very demented, very, they end up worse. They can't do very much. You've just debilitated them even worse, but you made their numbers look prettier. So we don't want to do that either. We would rather select a medication that would get their pressure down to prevent strokes and heart attacks, but they're still functional and still able to do what they want to do and not more confused, more demented, more passing out, more dangerous. Quality of life, we want to keep that as high as possible.
Is that one of the reasons behind some of the use of a combination therapy that you mentioned earlier, where there might be, rather than going with one agent, there's two or multiple, the idea being that if we're using these lower doses of each, it in some way might be less taxing, for lack of a better term, in terms of these side effects?
Yeah, absolutely. When you use a lower dose ACE inhibitor with a lower dose hydrochlorothiazide with a lower dose calcium channel blocker or whatever, you eliminate most of the side effects. So similarly, like with statin medications, if we use a low dose statin plus Zetia, which is not a statin at all, it just blocks you from absorbing back your own cholesterol in your intestines, you can get away with lower dose medications with much lower incidence of possible side effects. So for example, the cough with ACE inhibitors or the diabetogenic, effects of certain beta blockers, or the erectile dysfunction, or the fatigue, or the weight gain, whatever it might be, you can minimize the amount of side effects while still maximizing blood pressure. If you use 2 or 3 low doses of medications versus a whopping dose of one medication, absolutely you can reduce the amount of side effects to almost none.
Fantastic. To move into some of the potential lifestyle interventions we have, and we'll start with diet, as this is often the focus of this podcast. And I suppose there's 2 elements we could look at. One would be from a dietary pattern perspective, and then one is from actually specific nutrients. If we start on that nutrient level, of course, the main one that comes to mind for most people is going to be sodium, and with good reason. We have a incredibly robust evidence base in this area, but one of the, I suppose, challenges, at least in modern times with information that's around, is unfortunately people seeing mixed messaging about salt and sodium and how that actually is implicated in some of these negative health impacts, for example, with blood pressure, which when you look at the evidence is absurd to even think of. But I'm always interested to hear from someone like yourself who, as opposed to me, actually has to face these patients at the end, like the people that are receiving this information and seeing how this manifests in the real world. So when we think about sodium and blood pressure, maybe briefly for people, what is the best way to think about the strength of the evidence in that area? And then from that, some of the potential impacts we can see from getting changes in someone's sodium intake.
So I just wanted to comment on what you said. So there's a lot of these
people online, these medfluencers, we call them, or healthfluencers, that are like, eat all the salt you want and it lowers your blood pressure and all of this, because some of them just have books to sell. I mean, first of all, no one's going to buy a book that says eat fruits and vegetables, right? I mean, if you wanted to sell a book or supplements and make a lot of money, you wouldn't just give people reasonable advice. You wouldn't just say, hey, if you eat some fruits and vegetables and some lean meats and get enough protein and cut calories, you'll lose weight, start walking, lift weights. That's not sexy. No one is going to buy that and be like, oh my God, there's this guy, his name is Danny, and he talks about nutrition and all you got to do is be healthy. Like, it's not exciting. But if you sell a book says how we got salt wrong, or eat tons of salt, or, I don't know, eat tons of cholesterol and it's okay for you, or like whatever it might be, just something contrarian. It's good. You can sell books, you can sell supplements. A lot of people do this. One thing I will mention is that for your audience, like how to detect one of these crazy people that's lying to you or just full of nonsense. One way to detect that is if they portray themselves as somebody that has discovered something that all of academia and all of the world of science and all of the world of cardiology and medicine hasn't discovered, they're probably lying. Like, what is the likelihood that the European Atherosclerotic Society, the European Society of Cardiology, the American College of Cardiology, the Australian, New Zealand, Russian, Middle Eastern, Spain, everybody, what is the likelihood that these billions of physicians that write the guidelines and evaluate evidence, that it's their specialty to evaluate this evidence, got it all wrong, and this one guy selling a salt book has got it right? I mean, right. And of course you can cite science, like, you can go on PubMed and you can search studies that show that consuming salt improves blood pressure or improves lifestyle or makes you lose weight, or, whatever it might be. You can find a study to prove almost anything. I always tell people that, like, if you want me to find a study that says eating salt makes you healthier, I can find it. I can find tons of studies on this, but what does the totality of evidence say? So these people will write a book, and there's one of these books called The Salt something. I don't remember what it's called.
Salt but I'm Fix, sure this, I believe, is one that we've
written by a person who calls himself Doctor or something. He's not actually a doctor. I think he's a pharmacist, but in the US it is a doctorate degree. And I'm not saying it's bad. I'm married to a doctor who is a pharmacist, so I'm not saying anything bad. If you're a pharmacist that is a doctor of pharmacology, don't come after me. I'm just saying that this guy is not actually a physician that treats people with hypertension, but he finds a few studies and tells a couple of great stories on how salt is a myth and it's not real and it's fake and whatever. Makes a lot of money, sells a lot of contrarian books. So you got to be careful when somebody portrays themselves as knowing more than all of academia, all of cardiology, all of, the European Society of Cardiology. Like, this is just insane. Either they're narcissistic and crazy and think they know more than everyone else, or they're just lying to sell products, whether it's supplements or books or whatever it might be. So be careful when you have somebody that says something that goes against everything that you've been told by everyone else. And there is always like this, recently, especially, there's this people that like don't trust institutions. They don't trust the government. They don't trust the doctors. They don't trust the whoever. And maybe for good reason. We've given people lots of reasons not to trust us in medicine, but like science advances, we learn. People are like, well, back in the 1800s, you guys used to do bloodletting. Okay. That was 250 years ago. We don't recommend that anymore. And we've learned, not a big deal. Just like pilots learned how to fly planes better or whatever it is. So the guidelines generally today, whether it's the European guidelines or the American guidelines, recommend up 1,500 milligrams or 1.5 grams of salt per day or less, or take what you normally consume and subtract 1,000 milligrams. That is the single most effective dietary or lifestyle modification you can do to lowering blood pressure. There's two things in nutrition that are very pro-inflammatory. One of them is salt and one of them is saturated fat. Both of those, for whatever reason, they reduce, blood flow in your arteries. They reduce your arterial stiffness and compliance. They make it very difficult to improve health outcomes. The other thing that makes a big difference is we want people to get about 3,500 milligrams or 3.5 grams of potassium in their diet. Foods that contain a lot of potassium are generally citrusy fruits. These are like your kiwis. Kiwi actually has one of the most. Kiwis, oranges, limes, lemons, those kind of things. It's kind of hard to get enough potassium in your diet. So if it's hard for you and you don't like fruits, maybe one thing you can do is you can get the salt called Nu-Salt or potassium chloride. It's instead of sodium chloride, instead of salt, it's potassium. Then you can sprinkle that on your food. It doesn't taste exactly the same, but it's close enough. Those are the two main dietary, at least, ways of improving your blood pressure. Now, obviously, if you're overweight, getting into a calorie deficit will make a huge difference. As weight comes off, your blood pressure will improve. Definitely exercise, whether it's aerobic or, resistance training. Obviously, in my world, being a certified personal trainer, cardio is great for you. Improves your cardiovascular markers, your outcomes, all of that. Lowers blood pressure, reduces the rates of heart attack and stroke, but also weightlifting has now been shown to reduce all-cause mortality, disease-specific mortality. It also improves your health span. If you're older and now you don't need a walker and you can step up and get out of a chair and lift some things over your head or, grab things out of the kitchen cupboard, whatever, obviously, resistance training makes a huge difference there. The other one would be to reduce alcohol intake or just eliminate it. So those are kind of the most important dietary interventions / lifestyle, the exercise. Those are the most important lifestyle modifications you can do. If you had to rank them, top, would be less salt, more sodium, exercise, fruits, vegetables, calorie deficit to lose weight if you need to lose weight. Those would be, kind of the top 5 or 6 things to do. Obviously, quit smoking, quit alcohol, all that kind of stuff as well.
Fantastic. Yeah, it always is amazing when you look at that literature base on sodium and blood pressure, just how incredibly strong it is and the magnitude of effect that we're seeing in those, and then also how that translates to actual events as well. It maps onto it pretty well. So, and I mean, for me, you mentioned these people who spread nonsense around online, and particularly in relation to things like salt and blood pressure being one example, but also the saturated fat and LDL cholesterol one is another classic example. Why these tend to be the ones that I would say infuriate me the most is because of the harm that you get off the back of it, right? So previously the Gary Brecka example with the hydrogen and water and all this type of stuff, sure, it's wasting people's money and scaremongering and stuff, but it's probably not having the same degree of real impact that these are having. And I mean, we could probably sit down and based on the audience size that are receiving those messages around eat more salt or eat more saturated fat, and then knowing the prevalence of these in the population, we could probably see the degree of literal events that this type of information is causing. And it's why it's so troublesome. And as you say, it is just a playbook of how can we be contrarian? Let's take what is known and say they lied to us, and now we'll give it the counter narrative. And it's unfortunately common, but it obviously works in the sense that it makes money.
Yeah, the one thing I'll point out too, the European Atherosclerotic Society, a bunch of the authors, I know them, they recently wrote a paper stating that we could eliminate heart disease completely if we got people's lipids down to a low enough level, whether that's through dietary interventions, medications, whatever. We have incredible medications now. It's not just statins. We have multiple other options. But what they said is we could save 1 million lives per year. An additional 600 to 800,000 lives per year, not die. These people would still be around every year. So imagine over the next 20 years, that's almost 20 million people. If we just got people's lipids down, but we have these people online running around telling people that cholesterol doesn't matter when it's literally the most studied thing in the world. People I love these videos. They start out with, well, we don't know enough about cholesterol. Yes, we do.
we know a lot. It's the most studied thing in all of medicine because it's the number one killer. Now, obviously, it is way less. Deaths from cardiovascular disease decline every year since the 1960s, but currently, cancer is, creeping up, and they're about to intersect soon. But deaths from cardiovascular disease is still the number one. And we have people online telling you that, well, we don't understand it and we don't understand cholesterol and it's confusing. No, it's not. We understand a lot of it. It's the most billions and billions and billions of dollars every year are spent to understand cholesterol and heart disease. It's more studied than cancer, than orthopedic, bone fractures, than any other thing in medicine. Cholesterol is the single most studied and most targeted system in the body because we know so much about it. And we know if we found a way to fix this, people, like, they're even now working on, I'm sure you've read, there's this medication called inclisiran, where it's a twice a year injection that lowers your LDL cholesterol by about 52%. And it's based on CRISPR technology. It's like this mRNA silencing, almost like a gene therapy. They're working with this CRISPR technology to create medications similar to inclisiran, where it would be almost like a lifetime, or like you get it once every 18 months. You get an injection once in your life, maybe, and this is way into the future, but you get an injection once in a lifetime, and all of a sudden your LDL cholesterol is 30 for the rest of your life, almost like these people that live in the blue zones that have a PCSK9 gene loss of function mutation, where their LDL, they're walking around an LDL of 10, 15, maybe 20 for their entire lives. If they do everything else right, they could easily live to 100 or more. So we're working on things like this, especially where like one single gene loci or, location can make a huge difference. Like sometimes with diabetes, with blood pressure, with, they're looking at Alzheimer's now and Parkinson's and a few other things, where if we can change this one little thing in your genome, and this might be getting too advanced or, out of the topic of hypertension, but they have found one. There is one recently that was published about hypertension where they found one gene mutation. There was a medication similar to inclisiran where it's like a once a year infusion or a once a year injection that can reduce people's renal vascular hypertension significantly, if not eliminated completely, where you don't need to take medications anymore. So that one is coming soon, probably in the next 3 to 5 years, but it's in its final phases of being tested. But we have some tremendous technology. People always say, well, we want to be biohackers. Like most of these people are biohackers and life hackers, whatever they're called. Well, we have ways now, and you don't need to wear blue blocker glasses and do red light therapy. We have actual medications that can extend your life by 30 to 50 years. Why aren't you saying that these are biohacks? Because they can't make money off it. They can't sell it. You can't buy their red light face mask or, electromagnetic wands that you mix your water with. So the biohacking community could literally jump on stuff like this and be like, I want to take this. If I can reduce my blood pressure by 30 points for the rest of my life, or my LDL by 50% for the rest of my life, this is an amazing biohack. But they can't profit off of it and they can't make money off of it. So they don't really do it, but they'd rather sell you a bottle of nonsense that does nothing.
Exactly. I mean, if they were actually interested in people's longevity, that hack would be, go take a statin. Guess what? That's probably going to have a much bigger effect than anything else they're talking about. Before we finish up, you've given some really useful practical things there in terms of that ranking of things we can do from a lifestyle perspective. When it comes to diet, it's making sure that we're keeping sodium relatively low. This would obviously include added salt to the diet, but also foods that are highly salted, which typically tend to be more processed. You then said from there, we can go an additional step and look at potassium within the diet, which can come from a variety of different fruits and vegetables. There's also salt substitutes that we can add in to get some potassium up as well. And then those are layered on top of an overall healthy dietary pattern. In addition, things like minimizing alcohol intake. From there, you also briefly mentioned exercise, and I'm sure this is one that people are interested in. From the impact we see on exercise as a way to bring, let's say, blood pressure into range, what is that kind of relationship? Do we see that if, for example, we got someone to meet the current guidelines for physical activity, is that something that we would see a sufficient drop? Is there benefits to going beyond that? As in, is this a kind of a linear kind of association, or how would you walk through a patient to start thinking about that relationship between exercise and blood pressure, and what type of targets we might start giving?
So I think a lot of it depends on the patients. If it's a younger person who's quite healthy, there's no real limits to exercise other than your time and, level of accumulated fatigue. If you're, 20, 30, 40 years old, you're an athlete, you play soccer or football, and you don't have any other job, then you would exercise all the time. You'd always be training. If you're a person like us who's, 20, 30, 40 years old, who has a job, any amount of exercise is bonus. I lift weights almost 3 to 5 days a week, depending on the week. I do some cardio. I play basketball. I coach kids. And when we warm up, we run around a little bit. But it just really depends on how much time you have. The guidelines recommend moderate level intensity of about 150 minutes per week, or very intense of 75 minutes per week. And there obviously is an upper limit of benefits. I don't know that that's been clearly defined in the data, but my older patients that are not like us, they're not young, they're not healthy, they can't play sports, they can't do anything. Even just going on a walk is good for them. Whether if they get up and just walk after every meal or walk for 5 minutes a day. And I always tell my elderly patients too, like if you don't want to lift weights, fine. But how about if you sit on your chair and stand up 10 times a day? Just sit, stand, sit, stand. It's almost like a squat motion. At least that uses big muscle groups, kind of gets their muscles engaged. There's lots of metabolic benefit from having stronger muscles that are engaged and doing things. Plus their quality of life goes up. And I tell them even try to reach down and pick something up off the floor. Even just pretend, reach down, pick something up off the floor, do it again. It's almost like a deadlift, Romanian deadlift kind of pattern, or stiff-legged deadlift, whatever. But that is also like a movement pattern that helps. Reach above your head and pretend you're grabbing something, out of a kitchen cupboard or something. But just do some kind of movement pattern that you're able to do. Now, if you have all the time in the world, then, go running, go swimming, go play basketball, lift weights 3-4 times a week, whatever. It's a cumulative effect. If exercise also causes weight loss, let's say you hold your calories constant and you start doing exercise and now you've created a deficit with exercise, obviously, weight comes off. We know that I think the statistic was for every 5 kilograms of weight lost, your blood pressure goes down by 3 to 5 points systolic, something in that range. I don't remember off the top of my head. But if you do lose weight because of exercise or a calorie deficit, that will also help your blood pressure. Obviously, exercise can be used for many things: cardiovascular, improvement, muscle strength improvement, muscle hypertrophy, depending on what your goals are. But also, if you just use it for fun, you like walking the dogs, you like doing yard work, whatever. And if you hold calories constant and you do lose weight, that obviously helps with blood pressure control as well as other things, blood sugar control, insulin resistance, insulin sensitivity, cholesterol, even a little bit. It just really depends on what your goals are and how much you do. I don't think there's an upper limit. Obviously, there's a point of no returns. I mean, even in, exercise science, we know that after a certain amount of exercise, the amount of energy you can expend from exercise is capped. Your body will take away from your NEAT, your non-exercise activity thermogenesis, and you won't be burning calories forever. It's not a straight line. You can't just get on a treadmill and run for 18 hours a day or 24 hours a day and burn unlimited amounts of calories. Your body eventually shuts down. It takes away from your NEAT. That's an extreme example, but I think you understand what I'm saying. But there is an upper limit of, the point of diminishing returns. I don't know that that's been defined for blood pressure, but the problem with most people in the United States and around the world, Europe, we're not over exercising. We're not overeating fruit. We're not overdoing it. We're underdoing it. In most cases, people are very sedentary. They don't eat enough fruit. They don't eat enough vegetables. Some of these people online, they're fear mongering. Don't eat fruit. It's bad for you. It has so much sugar. There's no fear. Humans are not over consuming fruit. There's no
data sets in the world, whether you looked at, the pure cohorts or, any of these data sets that show that humans over consume fruit. It's just not possible. And there's no cohort studies or data that shows that humans over exercise. There's no place in the world where we need to tell people you got to slow this down a bit. You're going to die. There's nobody that's over exercising. So I think just telling people, if you're exercising, try to do a little more. If you're not, just try to do something. And of course, there's lots of things in between. So I think stressing activity of any sort that you enjoy, I'm sure you found this with your clients, as long as they enjoy it, they're more likely to keep doing it. The elderly obviously are the ones where we want them just to do something they enjoy. You're not going to tell a 70-year-old person, let's get you in the gym and start deadlifting, even though I would and I try, but they're probably not going to agree. But tell them, look, pick what you enjoy and just start there. You like swimming, go swimming. You like walking with your grandkids, go walk with your grandkids. If you like lifting weights and deadlifting, let's do it. No big deal. But definitely, I don't think we have a problem of over exercising and over consuming fruit. It's quite the opposite.
Yeah, that's absolutely the case. With that, we could have like one question and conversation would be, at what point potentially will we see that maximal benefit if we're aiming for, let's say, reducing blood pressure? But as you noted, the more pragmatic question most of the time is that the majority of people in the population don't even meet the minimum recommended targets for physical activity, never mind anything to even get beyond that. And so the challenge becomes, as you've highlighted, how do we get people even closer to that minimum target that we currently have through different means that are most likely they're going to continue. We're coming close to time here, Doctor. So before I get to the very final question, can you remind people again where they can find you on the internet, different places they can consume your content, and anywhere else you'd like to divert their attention towards?
Yeah, if you go to dralo.net/links, dralo.net/links, there's links to every one of my social media profiles. You can follow me. I'm on every app. If you just search Dr. Alo, DRALO, on any social media app you'd like, you'll find me, including Pinterest, even LinkedIn, Instagram, Facebook, Twitter, or X now. TikTok even, all of them. So just go to dralo.net/links and you'll find links to all my socials. And I try to answer all questions. I try my best to answer all the comments as much as possible. It's getting harder, but I'll even usually respond with a video. If you ask, my LDL is 110 and I do this and my blood pressure this and I'm taking this medicine, usually it's much easier to respond with a quick short video than to try to type out a paragraph of text.
Fantastic. And that will be linked in the description box for everyone listening, so you can click through there. That brings us to the final question that I always end the podcast on. And this can be to do with anything, even outside of what we've discussed today, if you wish. It's a broad, generic question, so apologies for throwing it out this time. But it's simply, if you could advise people to do one thing each day that might have a positive impact on any area of their life, what might that one thing be?
I would say give back to young people. There's a lot. If you have the ability and you've been blessed, you have a good job, you have a lot of time, you have a lot of resources, take some young people and go coach their football team or their soccer team, or create like a little, mentor group, have them follow you around. Like I get a lot of young people like, I want to see what a doctor does every day. So, we're like, come on, follow me around for a few days. Or coaching sports, just, it's not just about coaching the sports. Like you'll notice, a lot of times it's the interactions and the conversations we have during practice. They're like, hey, coach, my mom told me I should eat more broccoli, or just, I don't like broccoli. I hate broccoli. I'm like, well, why don't you just try it one day? Maybe cook it like this. Do you like, this? And, did you talk to your mom about that? Maybe do this, or, if you want, I can talk to your mom and dad for you. Like, even just like little conversations, but give back to young people, because I feel like in today's world, there's not enough of just giving back selflessly. Like, a lot of times you'll see me on the soccer field, like on my knees, tying a 5-year-old kid's soccer shoes. Who would think like a cardiologist that has, a large online profile would be like bowing down before a 5-year-old tying their shoes while the kid's like, come on, tie my shoes. But like things like that are very humbling. You put yourself in a good position to not, become arrogant or conceited, but also you're showing children, like, you're leading by example. You're teaching them teamwork, discipline, hard work, ethics even. So I think if you could give back to society, especially young people, I feel like young people probably don't have enough role models in their life. And maybe they do, I don't know. I'm not a psychiatrist or anything, but if you can give back in any way possible, I would highly recommend that. It's good for you. It's good for your soul. If you're a selfish person, you could view it that way, but it's good for the kids. It's good for society. They will grow up one day, hopefully inspired by you to try to also give back to society. It costs you nothing. Like, what is it? You're done with work at the end of the day. What does it cost you to go to practice for an hour or two and help the kids learn new skills, teach them football plays or how to, kick a corner kick or throw in a ball? All of those things, they seem like they're just sports related, but it's not. It's the interactions. It's the attitude. Some people come from homes where their parents are not very friendly and they're always yelling at them and they're not positive, and it's a negative experience all the time with adults. And you're showing them that adults can be friendly, they can be compassionate, they can be teaching in a fun way. I think that is super, super important. And I think if more people did that, the world down the road in the future will probably be a very, very much happier place.
Yeah, that's a fantastic point, because even anecdotally, I know that to be true of, if you think of most people when they think back to coaches or teachers or mentors that were most influential in their life, it wasn't the person that had the best tactical insight on this particular type of play, right? It was the person that basically treated them in a certain way that made them feel better about themselves or more confident in themselves, and then in turn helped other people, speaking exactly to your point. So a fantastic way to end this conversation. Dr. Allo, thank you so much for taking the time to come and talk to me and for the information you've shared. It's been a pleasure to chat.
Yeah, thanks for having me. I appreciate it.